So my next talk is on specular microscopy. So these are the points that I would like to cover. Now, as we all know, specular microscopy is a non-invasive photographic technique that allows you to visualize and analyze the corneal endothelial cells. Here, the instrument projects a light onto the cornea and captures the image that is reflected from the optical interface between the corneal endothelium and the aqueous humor. Approximately 0.022% light is reflected from this interface. The reflected image is analyzed by the instrument and displayed as a specular photograph. Now, what are the indications of doing specular microscopy? Now, these can be broadly divided into three categories. One, to study changes in the cell as well as its specific patterns, which help us in identifying conditions like Fuchs endothelial dystrophy, eye syndrome, or posterior polymorphic corneal dystrophy. Second, in certain preoperative situations before undergoing any intraocular surgery. And third group is to assess donor corneal tissue. Now, specular microscopes are of two types: contact and non-contact. Non-contact one is more popular. The analysis of these cells can be done by different methods. The most commonly followed method is automated analysis, where the machine automatically outlines the endothelial cells and calculates the cell density, cell size, and hexagonality. Then there is something called as a semi-automated mode, where the cell size, which is fixed in automated mode, can be modified manually depending on examiner's perception of the cell size. In manual analysis, you have something called as a fixed frame analysis, where cells within a fixed grid are counted. Then you have variable frame analysis. In this method, the user is required to define the area of analysis by outlining the cluster of cells, and it is done if the area of the cells is irregularly shaped or it doesn't fill the frame. In the center method, the user marks the center of each cell in a contiguous group. In the flex center method, it is based on center method only. Here, the outer boundary of all the visible cells are outlined, and then the center of each cell is marked manually, and then analysis is done. So what kind of assessment is done in specular microscopy? So basically you have two types of assessment. One is quantitative assessment, which gives information on cell size, shape, and number, and qualitative assessment, which helps in detecting abnormal cells and patterns. So what all points we should note when we get the report of specular microscope? So take this report for example. The topmost portion will have all the patient's detail, and you will have the point of cornea from where the image is captured. The most common is the central point, which is also mentioned there, but you can have image captured from paracentral points or peripheral points as well. Now let's look at the photograph of the endothelium. Adjacent to this photograph, there is tracing of the endothelial cells done by autoanalysis. In the center you have quantitative parameters, and in the extreme right you have graphs. And the first parameter that needs to be studied is cell density. Now, as we all know, endothelial cell is a monolayer of about 3,50,000 to 5 lakh cells that cover the whole posterior surface of the cornea. The normal density of the corneal endothelial cells is approximately 2,500 cells per millimeter square in the adult age, and it reduces by about 0.6% every year. So the cell density should always be compared to a particular age group. The normal values of different age groups are seen here. Next we come to pleomorphism. Pleomorphism is basically significant disruption in the regular hexagonal pattern of the endothelial cells that causes decrease in endothelial mosaic stability. So if a patient's corneal endothelium demonstrates less than 60% of hexagonally shaped cells, he or she is considered to have clinically significant pleomorphism. Because of its effect on fluid barrier function of the endothelium, presence of pleomorphism increases patient's risk of postoperative corneal edema. Polymegathism. Now, whenever an endothelial cell sloughs out, a gap is created, and to repair the gap, endothelial cells adjacent to the gap move in to fill the space. The endothelial cells either stretch or slide in different positions. This movement of endothelial cells create a variation in the cell size called as polymegathism. The rate of polymorphism is represented by coefficient of variation, and CV values below 0.31 are considered to be normal. Coming to the qualitative analysis, this picture is very important as it shows difference between guttate, pseudoguttate, and endothelial denudation. When we talk about corneal guttata, they are seen as dark areas of variable sizes in the endothelial mosaic. Very important to understand that dark areas are not because of the absence of cells, but because they protrude towards the anterior chamber. And the endothelial cells lying over the guttata doesn't come in the captured specular plane. So these guttata are formed by the secretions of collagen from the endothelial cells that form nodality on the posterior surface, and the endothelial cells wrap around and cover the corneal guttata. It goes through 5 stages of progression, from a small dark structure in the center of the endothelial cell to progressive coalescence of corneal guttata, making the normal pattern of endothelial mosaic impossible to visualize. Pseudoguttata, on the other hand, also appear as dark spots, but the difference is they are transient and they are basically reversible endothelial edema, which is associated with anterior segment pathology. Adjacent cells are also unaffected, thus they retain the normal endothelial mosaic pattern. So here we see a diffuse pseudoguttata which resolves over a period of next 4 days. The list of causative factors are huge, but mainly due to infection, post-surgical inflammation, and medication toxicity it can happen. Now let's look at some patterns which are typical of certain conditions. First is iridocorneal endothelial syndrome. Now we know that normal endothelium has a light center with a black border. In ICE syndrome, the cells appear as dark with central highlights and light peripheral borders. This is a very typical finding. In posterior polymorphous corneal dystrophy, the vesicular lesions are considered to be the hallmark of the disease, and they are present in almost all patients. They are seen as circular dark rings around the lighter center in which cellular details are evident. These vesicles are filled with fibrillar or collagenous material and are not fluid-filled spaces as the term vesicle would imply. Now let's look at some examples. Now this is a specular microscopy report of a patient with dense cataract. Now parameters like cell density, CV, and hexagonality are all normal. So this patient has good endothelial parameters to go ahead with the surgery without need to take extra precaution. Now the most common scenario is when a patient with cataract surgery with guttate comes to you, you order a specular microscopy and a report comes to you which shows that one of the eyes has a CCT of 478 with a cell count of 3428. In the other eye, the CCT could not be measured but had a cell density of 3072. If you look at CV and hexagonality in both the eyes, they are significantly abnormal, indicating poor quality of cells. Now, if you were to rely only on the cell density as a parameter to decide, it can lead to a big surprise in the post-op period. So one point if you were to take from this talk, it would be measuring endothelial density in presence of guttate is inaccurate and unhelpful, because guttate actually obscures cell that may be overlying them, and regional variations in the guttate density can lead to vastly different endothelial cell densities of the same cornea. So ultimately, endothelial cell density does not equate to endothelial function. Fuchs endothelial dystrophy goes through different stages, and we have to decide at which stage one should do a combined surgery, that is endothelial transplantation with cataract surgery. The most common stage of Fuchs is when it is present without edema. The next stage is when there is subclinical edema, and the final stage is when you have a clinically evident edema. Now, in the recent years, Pentacam has found some role in diagnosing subclinical edema. Look at this picture. So the top two photos are from 2012, and you see the corneal thickness which is shown here, and it's showing concentric rings indicating proportionate increase in the corneal thickness as one goes to the periphery. The other photo shows back elevation which is normal. In 2018, the same patient, the corneal thickness map rings have become irregular, and then there is displacement of the thinnest point of the cornea. The elevation map shows a red spot with negative value indicating that there is a focal depression on the posterior surface. So these are the three important features of subclinical edema, and if they are present, then the patient would definitely need a combined surgery. Another important point is asymmetric CCT. In this example, CV in both the eyes is abnormal, but the left is worst. But if you see the corneal thickness in the left eye, it is quite high compared to the other eye, indicating that the edema is already set in due to poor endothelial function. So to conclude, specular microscopy is an important tool in differentiating corneal conditions and predicting prognosis. It is useful in planning adequate intraoperative measures, and it is useful in IOL decision making, like avoiding multifocal IOLs in patients who have features of Fuchs endothelial dystrophy. Thank you.